Hello everyone. Let us begin with the new unit, that is the drugs acting on the autonomic nervous system. So in this particular unit we shall cover the drugs which are acting on the both the autonomic nervous system, parts of the autonomic nervous system, that is the parasympathetic system and the sympathetic system. Okay, so we shall begin with the first system, that is the parasympathetic system. So we shall cover the drugs which are acting on the parasympathetic system. So this particular chapter, as the name implies, cholinergic drugs. Okay, that means it acts on the cholinergic system, that is the parasympathetic system is also known as the cholinergic system, because acetylcholine is the main neurotransmitter over there, so it is also known as the cholinergic system or the parasympathetic system. So accordingly, the drugs which are acting on this system, okay, these are actually acting and it is producing similar actions as if this system is stimulated. So such type of drugs are known as cholinergic drugs, or these are also known as cholinomimetics, that is they mimic the action of acetylcholine, so that's why they are known as cholinomimetics, or they are also known as parasympathomimetics. So they mimic the action of the parasympathetic system, so by producing the actions similar to the acetylcholine, which is the transmitter which is released when this system, parasympathetic system, is stimulated. So coming to the outline of this chapter, before going into the actual cholinergic drugs, we shall cover the cholinergic transmission. So we will see how exactly the neurotransmitter, that is the acetylcholine, how it is synthesized, where it is exactly stored, how it is released or how it is metabolized, and what are the different receptors through which it mediates the action, and what are those effects which are seen after stimulation of those receptors. So all that will be covered before we go into the actual drugs which are acting on the parasympathetic system. Okay, the drugs which produces similar actions. Okay, so such type of drugs are known as cholinergic drugs. So under this we shall cover the definition of cholinergic drugs, classification of the drugs, and the two main classes, that is cholinergic agonists and the anticholinesterases, in detail. So before going into the actual drugs, we shall see how exactly this cholinergic transmission is taking place. What are the different aspects? So as I've told you earlier, acetylcholine, which is also denoted as ACH, this is the accepted short form. A and C are capital and H should be small. So ACH or acetylcholine, this is the major neurohumoral transmitter at all these sites, autonomic, somatic as well as the central sites. Okay, so we shall, in this particular part, we shall see how exactly acetylcholine is synthesized, stored, and how exactly it is released or metabolized, and which are those receptors through which it will mediate all those actions. When normally ACH is released as a neurotransmitter, what are those different types of receptors through which it can mediate its different types of actions. Now coming to the first part, that is the synthesis of the acetylcholine. So it is synthesized locally in the cholinergic nerve endings, and this is the pathway which is followed for synthesis of the acetylcholine. This is the structure of acetylcholine chloride. Okay, so the first step, okay, that is the activation of the formation of the acetyl coenzyme A with the help of ATP, acetate and coenzyme A. So all these with an acetate activating reaction results in formation of the acetyl coenzyme A, which in turn is utilized as a source of acetyl, as you all must be aware of. This is the main source of acetylcholine, acetyl for the acetylcholine. So this group acetyl, it gets transferred on this choline with the help of this enzyme choline acetyl transferase. So as the name implies, on choline the acetyl group is getting transferred. Okay, it's just a one step reaction by which the acetylcholine forms, and this coenzyme A, it acts as a carrier for this acetyl group. So it is just set free, and then again it will find a new acetate group to form a new acetyl coenzyme A, which will be utilized for formation of new acetylcholine. Okay, so this is the synthesis of acetylcholine. Now the synthesis of acetylcholine, it can be blocked by this particular hemicholinum. Now how it acts is, it acts by blocking the choline uptake, which is actually the rate limiting step. Okay, so this is one of the requirements, right, for the formation of acetylcholine. Choline is required. So the uptake of this choline in the neurons, okay, cholinergic neurons, this acetylcholine, it is synthesized locally, right, in the cholinergic neurons. So its uptake within the neurons, that is blocked by hemicholinum. So as a result of this, synthesis will be affected. So this is how the synthesis of acetylcholine takes place. Okay, this is choline acetyl transferase. This is the enzyme which is present in the cholinergic nerve endings. So it results in formation of ACH, which is stored and it is further released as and when it is required. But from where this choline comes? So this choline, it comes from the breakdown of acetylcholine itself. So it is recycled. Okay, so whatever choline is there, it is recycled by taking back inside the cholinergic nerve endings with the help of this transporter. Now what hemicholinum is doing, it is inhibiting this uptake of choline. So if the availability of choline is decreased, if this transporter is inhibited, obviously choline will not be available for the synthesis of acetylcholine. So that's how it is causing the depletion of the acetylcholine. Next is the storage of acetylcholine. So most of the acetylcholine which is formed within the cholinergic nerve terminals, it is basically stored in the form of an ionic solution in the synaptic vesicles. Okay, so there will be small membrane bound vesicles into which this acetylcholine will be stored. Okay, so this synaptic vesicle wall, it has a transporter, an active transporter, which takes up the acetylcholine and stores it inside this membrane bound vesicles. Of course, some of the acetylcholine is also available in the free form in the cytoplasm also, but most of it will be stored in the synaptic vesicles. Okay, now this active transport which is utilized for the storage of acetylcholine, this one, it can also be blocked by this particular substance, that is vesamicol. Here vesamicol, it can inhibit this transporter. Okay, minus sign indicates the inhibition. So this active transporter which takes up the acetylcholine which is synthesized in the cytoplasm and it stores it inside the vesicles, but this transporter can be blocked by the vesamicol. So that's how it will result in the depletion of the acetylcholine. Okay, so storage is getting affected. So whenever it is required, it will not be available in the stores, okay, in the form of vesicles. Then the next step is the release of the acetylcholine. Okay, now release of acetylcholine from the nerve terminals, it takes place with the help of the process of exocytosis. One must be aware of what exocytosis is. Now we have seen that the storage takes place within the synaptic vesicles, right? So acetylcholine is stored within the vesicles over here. Okay, so when an impulse comes over here, when this nerve is stimulated, obviously that impulse is further, or that signal is further carried by this acetylcholine, right? So this acetylcholine which is stored, it will be released from this synaptic vesicles by the process of exocytosis. What will happen? This vesicle, it will move towards the exolemma and it will get attached over here and the outer wall will break open. So as a result of this, whatever is stored within the vesicles, it will be released into the cleft. As you all must be aware of, any two neurons, they are not in contact, physically in contact with each other, or whatever effector cell on which ACH will act, that is also not in physical contact with the neurons. So there is a gap. Okay, and that signal which is brought by this nerve, it is carried through this acetylcholine. So it will bind to appropriate receptors on the effector cell, or it will bind to the receptor on the next neuron, and it will transmit the signal. So the release of acetylcholine, whenever any signal comes, the acetylcholine will be released into the cleft, okay, or the synapse, by the process of exocytosis. Okay, now simultaneously the release of acetylcholine, it may take place from a number of nerve terminals. Okay, so in a synchronized manner, the release of acetylcholine from a number of nerve terminals or from a number of neurons may take place simultaneously. Now this release of acetylcholine, this can also be affected by two toxins. Okay, the first one is the botulinous toxin. This inhibits the release of acetylcholine. Okay, so this is the one, botulinous toxin. It will simply inhibit the ACH release into the synapse. It will not allow the ACH to get released by the process of exocytosis. Whereas there is one more type of toxin, that is black widow spider toxin. It induces the release actually. Okay, it induces the release, because of which whatever stored ACH is there, it will get depleted. So entire amount will be massively released by this particular black widow spider toxin, as a result of which the stores of acetylcholine will get depleted. It will get over. So unless and until new acetylcholine is synthesized, it will not be available for the release. So these are the two types of toxins, one which is directly inhibiting the release, and the second one which is causing the release so that the stores are depleted. Then coming to the next part, that is the destruction or the metabolism of ACH. Now once the ACH is released, as the impulse comes or as the signal comes, the ACH will be released, right, from the stored vesicles as and when it is required. Now once it is released, it will act onto the respective receptors and it will transmit its information. So once it has done, immediately the ACH will be broken down by the process of hydrolysis. Okay, so whatever ACH is released in the synaptic cleft, it immediately gets hydrolyzed. Its its lifespan is very short, so it immediately gets hydrolyzed with the help of this enzyme cholinesterase. Okay, so this is the enzyme involved in the metabolism of acetylcholine, which is mainly metabolized by the process of hydrolysis. Now this enzyme cholinesterase, it is found in two forms. Okay, there is one enzyme which is specific for the metabolism of only acetylcholine, and that enzyme is known as acetylcholine esterase, or this is the abbreviation ACH for acetylcholine, E for esterase. Okay, or it is also known as true cholinesterase. So this is a specific enzyme for metabolism of acetylcholine, whereas there is one more type of enzyme which is a non-specific one, and it is known as butyryl cholinesterase, or BUCHE, or it is also known as pseudocholinesterase. So as the name implies, it is not meant for specifically for the metabolism of ACH, but it can metabolize the other types of esters in the body which may enter or which may be ingested. So mainly this butyryl cholinesterase, which is found in the plasma or in the other sites, it mainly serves for the metabolism of the ingested esters, whereas whereas the acetylcholinesterase is the enzyme specifically involved in the inactivation of the acetylcholine. So again, the destruction is also of one step. Acetylcholine, in the presence of acetylcholinesterase, it is broken down to choline and acetate, and this choline, it will be recycled, as I have told you that after the metabolism. So once it is released, it will act onto the receptors and will immediately get metabolized by this enzyme acetylcholinesterase. ACHE is the abbreviation for acetylcholinesterase. So it will act on ACH, which will be broken down into acetate and choline, and this choline, it is taken back, right, with the help of this transporter, and it is recycled. It is used for synthesis of new molecules of acetylcholine. Now, coming to the next part, that is the cholinoceptors or the cholinergic receptors, through which actually the acetylcholine will mediate its action. So basically, these cholinergic receptors are of two types, muscarinic and the nicotinic. Now the muscarinic receptors, these are G protein coupled receptors, and the nicotinic receptor, this is an ligand gated cation channel, actually sodium ion channel it is mainly. Okay, so further this two types of receptors are again subdivided. Okay, muscarinic receptors, it is denoted by capital letter M, and it is divided into again 5 subtypes: M1, M2, M3, M4 and M5. Now physiologically, the first 3 are playing most of the important roles, through which the actions of most of the actions of acetylcholine are mediated through M1, M2 and M3. So we will see these 3 receptors in detail. Okay, and this nicotinic receptor is divided into 2 subtypes. It is denoted as capital N for nicotinic receptor. Okay, so these again are subdivided into 2 types. Earlier they were known as N1 and N2, but then later on, based on their specific location, they were renamed as NM and NN. NM are those nicotinic receptors which are present on the skeletal muscles, and NN are those which are located on the autonomic ganglia. Okay, so this is how they are subclassified based upon their location and their transducer mechanisms. Now coming to the details about the muscarinic receptors. I have told you the first 3, M1, M2 and M3 are quite important, right? So we will focus more on these 3 types of receptors. Okay, so this is the table which is describing the location and the function of acetylcholine, which is mediated through that particular type of receptor, whether it is M1, M2 or M3. So it shows the location and the function which is produced by stimulating this particular receptors at this location. Then it also describes the nature of the receptor. This is a G protein coupled receptor, so which type of G protein is involved over here. So based upon that, it is again discussed over here, and the transducer mechanism, exactly which pathway is followed by the particular receptor, right? We have covered the transducer mechanisms also earlier, and also this particular table will tell you which are the agonist and the antagonist of the acetylcholine at these particular subtypes of receptor. There are specific agonists and the antagonists at specific subtypes of the receptors. Okay, so to start with the first type, that is the M1 receptor. So the first location, there are multiple locations. So first one is autonomic ganglia. So here it results in depolarization. So it will stimulate the autonomic ganglia. So wherever it is supplying, that area will get stimulated. Then the gastric glands. So here it results in histamine release or acid secretion is promoted as a result of stimulation of M1 receptor in the gastric glands. In the CNS also M1 receptors are present, and here it subserves for the learning or the memory and the motor functions are carried out in the CNS by the M1 receptor. Now coming to the nature, it's it involves a GQ protein. Okay, So there is a coupling protein, right? So it involves the GQ. There are so many GQ, GI, GO, and so on. Then the transducer mechanism, the pathway which is followed. So it follows this IP3-DAG pathway. So it increases the cytosolic calcium ions. Again, apart from this, phospholipase A2 is also stimulated. As a result of this, PG synthesis is enhanced. Selective agonists include, this is the code given to this particular newly introduced agent, NCN343A or oxotrimorin. These are the agonists, and antagonists include pyrenzapine and telenzapine. Then coming to the M2 receptor, basically this M2 receptors are found in the heart. Okay, main receptor found in the heart, muscarinic receptor found in the heart is the M2 receptors. So let us see in heart exactly which are the areas where it is found. In the SA node, which is a pacemaker which is responsible for generation of the impulses, it results in the hyperpolarization. Okay, action potential we have seen, the depolarization phase and the repolarization phase and the hyperpolarization, where it goes below the basal potential or the resting potential. It goes below that, so it causes the hyperpolarization. So as a result of this, depolarization is reduced. Now unless and until there is depolarization, an impulse generation will not take place. So the number of times the impulse is generated by the SA node, that is reduced as a result of hyperpolarization. Okay, so what will happen? The rate of impulse generation is reduced. So obviously the number of times the impulse is generated is equal to the heart rate, right? So what will happen? As a result of this, it will result in the decrease in the heart rate, that is bradycardia will be produced. Then next location is the AV node. So it involves in the conducting system of the heart. So M2 receptors over here, when they are stimulated, it will result in decrease in the velocity of conduction. So conduction of that impulse which is generated in the SA node, altogether impulse generation is slowed down, plus the conduction is also slowed down over here because of the stimulation of the M2 receptors in the AV node. Again, M2 receptors located in the atrium, when they are stimulated, it will result in shortening of the action potential duration. So as a result of this, the contractility also is reduced, okay, by its direct action on the atrium. Action potential duration is also shortened and the contractility is also reduced in the atrium. In the ventricles also the contractility is reduced, but it is slightly reducing the contractility. This action on the ventricles is not very much significant. Apart from this, this is to do with the heart. Apart from this, the M2 receptors are also located in the cholinergic nerve endings also. Okay, so here if you can see this picture here, right? So this is the muscarinic receptor, right? So this is the cholinergic nerve ending. So here also muscarinic receptor is located. Now see, when ACH is stimulating this receptor, what it is doing? It is inhibiting the release of ACH. Okay, so these are the autoreceptors. Okay, autoreceptors are the same type of receptors which are located on the same type of nerve. Okay, so this is the cholinergic receptor which is located on the cholinergic neuron. So this is an autoreceptor. Now what is the function of this autoreceptor? To control the release of ACH. When it is stimulated, it will itself control the release of ACH. It is inhibiting the release of the ACH. Okay, so cholinergic nerve endings, M2 receptors, they decrease the ACH release. Next, it is also located in the CNS, where it mediates actions like tremors and analgesia. Also, M2 receptors are found in the visceral smooth muscles, wherein it results in the contraction of the visceral smooth muscles. Now coming to the nature, here GI and GO coupled proteins are involved. Transducer mechanism involved potassium channel opening, so ion channel is involved over here, and decrease in the CAMP concentration. Selective agonist includes methacholine and antagonists include methotrexate and tryptophan. Then the next subtype of muscarinic receptor is M3. Basically, M3 receptors are found in the visceral smooth muscles. So here stimulation of these M3 receptors will result in contraction of the smooth muscles. Also in the iris of the eye, also M3 receptors are present. So here it contracts the circular muscle or the sphincter pupillae and result in constriction of the pupil. So it will result in meiosis. Also ciliary muscles in the eye have the M3 receptor, which results in contraction of the ciliary muscles. Exocrine glands also contain M3 receptors, which when stimulated results in secretions from all these exocrine glands. Then vascular endothelium, that is the endothelium of the blood vessels, it also has M3 receptors. Now here when these M3 receptors are stimulated, it will result in the release of this nitric oxide, which is endothelium dependent relaxing factor. So as a result of this, the smooth muscles in the vascular endothelium will be relaxed. So it will result in vasodilatation. So fall in BP will be mediated by this particular action. Then the nature of the protein which is involved is GQ protein. Transducer mechanism involved, it is quite similar to M1 receptor, that is IP3DAG, and increase in the cytosolic calcium. Phospholipase A2 synthesis is or it is stimulated and it will result in increase in the PG synthesis. Selective agonists include bethanicol and antagonists include solifenacin and derifenacin. Then coming to the subtypes of the nicotinic receptor, that is NM and NN receptor. Coming to the location, again the same type of description is given over here. Location and function, mainly this NM receptor, as I have told you earlier, it is mainly found on the skeletal muscles in the neuromuscular junction. So here it will result in depolarization of the muscle end plates and it will result in contraction of the skeletal muscle. Now this particular receptor, it is actually a ion channel. It has an intrinsic ion channel. So that ion channel itself is acting as a nicotinic receptor, that is NM receptor. It has 5 subunits, 2 alpha, beta, eta or gamma and delta subunits. So that's the nature of this this particular receptor. And the transducer mechanism involved opening of the ion channels, that is either sodium or potassium ion channels will open. Then the agonists include PTMA and the nicotine. Nicotine is an important agonist, and the antagonists involve the tuberculin and the alpha bungarotoxin. Then the NN receptor, which are mainly found in the autonomic ganglia, it will result in depolarization. So as a result of this, the postganglionic neuron, it will get stimulated. So impulse will be generated, and wherever it is stimulated, that area it will get stimulated. Apart from this, NN receptors are also found in the adrenal medulla. Here stimulation of NN receptor, it will result in catecholamine release. Adrenal medulla, it synthesizes the catecholamines which are found in the body. Adrenaline, noradrenaline, dopamine. These are synthesized mainly in the adrenal glands. So their release will take place. Apart from this, CNS also has some of the nicotinic receptors. So depending upon the site where exactly it is located, either excitation or inhibition may take place. Now coming to the nature of this particular receptor, again it is an intrinsic ion channel. Okay, it is again having a pentameric structure. 5 subunits are there. But here, unlike NM receptor, here there are many types of subunits, right? Alpha, beta, eta or gamma and delta. But here the entire channel, it is made up of either alpha or alpha beta subunits. Okay, gamma, eta or delta subunits are not present over here. Okay, and the transducer mechanism again involves the opening of the cation channels, that is either sodium, potassium or calcium ion channels will open. Agonists include DMPP and nicotine, and the antagonists include hexamethonium and trimethophan. So this is to do with the cholinergic transmission. Now coming to the actual drugs, that is the cholinergic drugs. or these are also known as cholinomimetics because they produce the action similar to stimulation of the cholinergic system or the acetylcholine, or parasympathomimetics because they are producing the action similar to stimulation of the parasympathetic system. Okay, now coming to the definition of the cholinergic drugs. So these are the drugs which produce action similar to that of ACH. Now, how it is producing these actions similar to that of ACH? There are two ways by which it produces action similar to ACH. Okay, now in this particular picture we have seen earlier, ACH, when any cholinergic nerve ending, it receives the stimulation, ACH which is stored, it will be released in the synapse, and either it will transmit its signal to the next neuron or it will act on the effector cells, right? This is what we have seen. This is the normal neurohumoral transmission which takes place in the parasympathetic system or cholinergic system. Now, how these cholinergic drugs are acting? They can act by two ways and they will have action similar to that of acetylcholine. Okay, either they will directly interact with this cholinergic receptors. These are the one, nicotinic and muscarinic receptors. So what these cholinergic drugs can do is they can directly bind to these receptors and stimulate them, right? So they will produce the action similar to that of ACH if they are able to bind and stimulate this receptor, right? So such type of drugs are known as cholinergic agonists. So they are acting as agonist at these cholinergic receptors. So they can bind and also induce the conformational changes and stimulate this receptor. Okay, so this is the first type of cholinergic drugs. Or there are certain other types of cholinergic drugs which can produce action similar to ACH by increasing the availability of ACH at these sites. Now, how they can increase the availability of ACH? What did I tell you about the destruction of the ACH? Once it is released, immediately it will get metabolized, right, with the help of this enzyme acetylcholine esterase. It will get hydrolyzed into choline and acetate immediately. Okay, so what we can do is another way by increasing the availability of ACH to produce the action similar to that of ACH. Okay, so these will have direct effect on the receptors, but these drugs, anticholinesterases, they act indirectly. They themselves will not go and bind to these receptors, but what they will do? These are the ones, anticholinesterases. They will inhibit this enzyme acetylcholine esterase. That's why they are known as anticholinesterases. Okay, so please don't get jumbled between these two. Capital A, capital C, H, E stands for acetylcholine esterase, which is the enzyme involved in the metabolism of ACH, whereas anticholinesterases, there is no such abbreviation. Abbreviation is this one, anti-CHE. Okay, usually people get confused between these two. Okay, ACHE is the acetylcholine esterase involved in the metabolism of acetylcholine. Okay, whereas anticholinesterases are the drugs which can inhibit this enzyme acetylcholine esterase. As a result of this, what will happen? The metabolism of ACH will be inhibited. It will not be broken down, so it will remain here for a longer period of time and it will act on the receptors, right? So these cholinergic agonists, they act by directly interacting with the cholinergic receptors, whereas anticholinesterases act indirectly. They themselves will not go and bind to the receptor, but how they will act? They will increase the availability of ACH by preventing their metabolic breakdown. Okay, so this is to do with the cholinergic drugs definition. So whole chapter will focus on these two classes. Okay, so coming to the classification. So as I've told you earlier, the first type of cholinergic drugs are cholinergic agonists. These will go and bind to the receptors. Again, these are of two subtypes. Choline esters, that is acetylcholine, methacholine, carbachol and betanicol are the examples, and the second one is the alkaloids which are obtained from the natural sources. So these are of three types, that is the muscarine, pilocarpine and the arecol. Then the second class is the anticholinesterases, which will prevent the breakdown of ACH, as a result of which it will potentiate the action of acetylcholine. Now again, these inhibitors of this enzyme acetylcholinesterase, these inhibitors can inhibit this enzyme either reversibly or irreversibly. Okay, enzyme inhibition, it can be reversible or irreversible. Okay, reversible in the sense what? That when these drugs bind to the enzyme activity will be inhibited. But once these agents are released from the enzyme will gain back its activity. Okay, so such type of inhibitors are known as reversible. So their action can be reversed. Whereas irreversible inhibitors are those which will permanently block that enzyme. They will inhibit the enzyme permanently so that it will lose its function permanently. So unless and until new enzyme is synthesized, it will not gain back its activity. So coming to the first type of anticholinesterases, these are the drugs which will inhibit the enzyme acetylcholinesterase involved in the metabolism of ACH. So coming to the first subtype, that is reversible inhibitors. Again, these are divided into two: carbamates and acridin. Carbamates are physostigmine, neostigmine, pyridostigmine, edrophonium, rivastigmine, donepezil and galantamine. And acridin, tecrine is the example. Then the second type of anticholinesterases are irreversible inhibitors, which will block the enzyme permanently. It will damage the enzyme. Okay, so this type of inhibition is irreversible. You cannot gain back the activity of this particular enzyme unless and until new enzymes are formed. Okay, again these are of two subtypes: organophosphates and carbamates. So examples of organophosphates which you all must be aware of, these are mainly used as the pesticides or insecticides: diaflos, ecothiopate, malathion, diazinon, tabun, serine, soman. There are so many examples. Okay, carbamates, these include carbaryl and propoxil. Okay, so irreversible inhibitors, these are usually of the toxicological importance. Okay, so some of them even have caused the harm in the human beings. So some of them have also been banned. Okay, so this is true with the classification. So we shall cover the first class, that is cholinergic agonists. Now here we will start with the pharmacology of cholinergic agonists. And here pharmacological actions of ACH are discussed as a prototype drug. Okay. Now these pharmacological actions again are discussed based on which type of receptor is being stimulated. Okay, so there are two types of cholinergic receptors we have seen, right? Muscarinic and nicotinic. So accordingly the actions of the ACH, basically the peripheral actions, these are classified as muscarinic actions and the nicotinic actions. Muscarinic actions are those which are mediated through muscarinic receptors. Nicotinic actions are those which are mediated through nicotinic receptors. And the central actions, okay, mind it, these were peripheral actions. Central actions, these are not so classifiable under whether it is muscarinic or nicotinic. So these are discussed separately. Okay, so pharmacological actions are discussed as three different points: muscarinic actions, nicotinic actions and the central actions. So coming to the first type, that is the muscarinic actions. So these are the peripheral actions. So first organ, that is the heart. We have seen under the table also where exactly those receptors are located. So we have seen that it is basically the M2 subtype of receptor which is located on the heart, right? So at different places it is located, and we have seen what are the consequences. So as we have seen that ACH, it hyperpolarizes the SA node. So because of the hyperpolarization, it will decrease the rate of diastolic depolarization. So impulse generation will be decreased. Okay, so as a result of decrease in the impulse generation, it will result in bradycardia, or it will result in the fall in the heart rate, decrease in the heart rate will take place, or sometimes even cardiac arrest may also take place. Apart from that, it is also located in the conducting system, AV node, his Purkinje fibers. So here the conduction will be slowed down. Okay, refractory period is increased. So as a result of this, the conduction is slowed down. Okay, so sometimes partial or even complete AV block may take place. Again, the force of atrial contraction is also reduced. We have seen that atria also contains the M2 receptors. So here it causes a decrease in the force of contraction of the atria. Even ventricular contractility is also reduced, but it is not much affected. Okay. Then next is the blood vessels. So here all the blood vessels, these get dilated. Okay. So as a result of dilatation of the blood vessel, what will happen? The diameter of the blood vessel will increase. So obviously what will happen to the pressure of the blood which is flowing through these blood vessels? Obviously when any size of the blood vessel it increases, obviously the pressure of the blood which is flowing through it will get reduced, right? So as a result of this, fall in BP will be seen, and flushing means here there will be because of vasodilatation, the blood flow into the local regions will be increased. So flushing will take place, especially in the blush region, that is in your cheek region. Then the types of receptors which are involved, these include M3 receptors, as we have seen under the table also. Okay, so here how it acts: by stimulating these M3 receptors located in the endothelial cells, it will result in the release of this EDRF, that is endothelium dependent relaxing factor. Now what is this endothelium dependent relaxing factor? It is actually nitric oxide or NO which is released. As a result of this, it will result in the relaxation of the smooth muscles of the wall of the blood vessel. So as a result of which the dilatation of the blood vessel will take place. So it will result in decrease in the BP. And the same mechanism is also responsible for the penile erection. Erection of the penis in males during the sexual intercourse, that is also mediated through this cholinergic neurons. Through release of NO, it results in dilatation of the blood vessels. So as a result of increase in the blood flowing to the penis, it will result in the erection, penile erection. Okay, this action is also mediated through M3 receptors. The next action is on the smooth muscles. So smooth muscles in most of the organs, these are contracted. Okay, so in the GI tract, the tone and peristalsis will be increased. Okay, and the sphincters will be relaxed. So as a result of which it will result in abdominal cramps. Okay, so due to the severe contractions of the smooth muscles, it can even result in abdominal cramps, that is pain will take place, abdominal pain, and it will result in evacuation of bowel. Passage of stools will take place. So whatever stools are present in the large intestines, these will be evacuated. Then again the peristalsis in the ureters. Ureters are the tube-like structures which are carrying the urine which is formed in the kidney towards the bladder for storage. So here also peristalsis is increased. Okay. Again the smooth muscles in the bladder are also affected. The detrusor muscles, they contract, those which are located on the upper side of the bladder. These are contracted, whereas the trigone and the sphincters of the bladder, these are relaxed. Trigone, these muscles are located at the base of the bladder, and the sphincters, which are actually controlling the flow of urine from the bladder into the urethra. So these are relaxed. So as a result of this, what will upper portion of the bladder is contracting and the lower portion is relaxing. Sphincters are also relaxing. So as a result of this, voiding of the bladder will take place. Passage of urine, it becomes easier. Okay, emptying of the bladder will take place. Then smooth muscles in the bronchi, these also can contract. So as a result of which the bronchial smooth muscles, they will contract and it will result in bronchoconstriction. constriction, and asthmatics are more sensitive towards this particular action. So as a result of this, bronchospasm, dyspnea, difficulty in breathing, or even precipitation of the bronchial asthma may take place. So you should be very careful. These type of drugs are contraindicated in the asthmatics because it can precipitate an asthmatic attack. Next action is on the glands. Secretions from all the glands which are innervated by this parasympathetic system, it is increased, and this action is mediated through mainly the M3 receptors and sometimes through the M2 receptors also. So all the secretions like sweating, salivation, lacrimation, tracheobronchial secretion, gastric secretion, all these are under parasympathetic control. So all of these will be enhanced. The secretions from all these types of glands will be increased. Pancreatic and intestinal glands are not affected over here. Even the milk or bile secretion is also not under the control of parasympathetic system. So they are not affected. Only sweating will be enhanced, salivation, lacrimation, tracheobronchial secretion and gastric secretion will be enhanced. Next action is on the eye. Contraction of the circular muscles of the iris, that is sphincter pupillae, will take place. Mainly the M3 receptor is responsible for this, and as a result of this it will result in miosis. Constriction of the pupil will take place. Apart from this, contraction of the ciliary muscles also take place. It also is supplied by the M3 receptors. So spasm of accommodation, increased outflow facility, that is the aqueous humor. So it will the outflow of aqueous humor will be promoted. So as a result of this, there will be reduction in the intraocular tension. So these type of drugs can be used in the treatment of glaucoma. It is a condition wherein the intraocular tension is increased. So it can help in reduction in intraocular tension. Then these are all the muscarinic actions. Next type of action is the nicotinic actions. So nicotinic actions, again based on the location of the two types of nicotinic receptors, autonomic ganglia on which the NN receptors are located. So both sympathetic as well as parasympathetic ganglia, these can be stimulated by the nicotinic receptors which are located on them. Okay, so these effects, these are mainly manifested at higher doses actually. Okay, higher doses are required to stimulate these autonomic ganglia. Even the high doses of ACH, which is given after atropine. Atropine actually is a muscarinic blocker. It blocks the muscarinic receptor. So once you give atropine and after that if you give high doses of ACH, it results in tachycardia and rise in BP. This is mainly due to sympathetic ganglia stimulation and release of the catecholamines. Then skeletal muscles which contains NM receptor. So application of this ACH to the muscle end plate, it will result in contractions of the fibers. Whereas the intraarterial injection of high doses, it will result in twitching and fasciculations. That is the persistent contractions or the contraction and alternative contractions and relaxations may take place. Then the CNS effects. Okay, as we have seen that these are unclassified, they are discussed separately. ACH as such, we have seen that it is acetylcholine chloride, right? So it has a plus charge. So it will not penetrate the blood-brain barrier. Even if you inject it intravenously, it cannot cross the blood-brain barrier. So no central effects are seen as such when it is administered, but direct injection into the brain, okay, or any other cholinergic drug which can enter the brain, it produces a complex pattern of stimulation followed by depression. Okay, so we have seen that certain receptors, it produces the site specific action, excitatory as well as the inhibitory actions. Then coming to the interactions. So this is to do with the actions, pharmacological actions. Now coming to the interactions, how they interact with the other drugs. Anticholinesterases, these potentiate the ACH markedly. Okay, as we have seen, it prevents the breakdown of acetylcholine. Okay, so it will potentiate the action. ACH will show more enhanced action. Okay, whereas methacholine, it potentiates to a lesser extent. Okay, whereas only additive action, no potentiation is seen when it is combined with carbachol or bethanicol. Okay, then atropine and its congener, as I've told you, this is a muscarinic blocker, so it can antagonize all the actions of ACH or any cholinergic agonist which is mediated through muscarinic receptor. So all those muscarinic actions which we have seen, all of them will be antagonized by atropine and the congeners. Next is the adrenaline. Adrenaline is a physiological antagonist. This is a receptor antagonist. Okay, it can bind to the receptor and block the receptor, so that ACH will not be able to bind to the muscarinic receptor. Okay, but adrenaline it is acting as a transmitter at the sympathetic system, and we know that sympathetic and parasympathetic system, it have exactly opposite actions, right? Okay, so when adrenaline, it stimulates the heart, acetylcholine will depress the heart. So both of them are having opposite action. Adrenaline can increase the heart rate, acetylcholine can decrease the heart rate. So both are having opposite action. So these are physiological antagonists. They will not actually interact with each other's receptor, with each other, but they are producing actions in the opposite direction, so that they are nullified. Then uses, as such, these cholinesters are rarely used clinically because of its acetylcholine, as such it has non-specific action. Bethanicol, sometimes it is used in post-operative or postpartum non-obstructive urinary retention. If urinary retention has taken place, for helping the person to pass the urine, it can be used, or neurogenic bladder, wherein the person loses control over the bladder sometimes. So in such condition, or congenital megacolon, wherein the intestines do not their peristaltic actions are affected, so to promote that, sometimes it can be used. Or in the GERD, that is gastroesophageal reflux disease, wherein the contents of the stomach comes out through mouth in the reverse direction, they will come into the esophagus. To prevent that, by increasing the GI tone and peristalsis, it pushes the contents of your stomach in the further direction, so that the backward movement will be prevented. Then the side effects include belching, that is passage of gases through the mouth, colic may be produced, or involuntary urination, or sometimes defecation, passage of stool may take place involuntary. Then flushing may take place due to the vasodilatation, sweating may be increased, fall in BP may be seen due to vasodilatation, and bronchospasm. So these are the side effects. Then coming to the next types of cholinergic agonists, that is cholinomimetic alkaloids, which are mainly found from the natural sources. So this include pilocarpine, which is obtained from the leaves of Pilocarpus microphyllus and certain other species. These shows the prominent muscarinic actions, and also it can stimulate the ganglia. Okay. This particular pilocarpine, it also increases the sweating, salivation. Also other secretions are also increased. Cardiovascular effects, these are quite complex. Smaller doses, it causes fall in BP, but greater doses, it causes rise in BP and tachycardia. So quite complex CVS effects are seen. Applied to the eye, it crosses the cornea, so it penetrates the cornea and it causes miosis, that is constriction of the pupil size may take place, ciliary muscles may contract, and as a result of facilitation of the outflow of the aqueous humor, it can also reduce the intraocular tension. Okay, so this action lasts for 4 to 8 hours. So this is used in the form of eye drops, and it is used in the treatment of open angle type of glaucoma. It's a third line treatment. It's not a first line treatment, but it is used in the treatment of open angle glaucoma. Initial stinging sensation, that is pricking sensation, will be seen in the eye. It may be painful. Okay, these are quite common side effects which may be produced when it is used in the form of eye drops. Then apart from this being used in the glaucoma treatment, it can be also used to counteract the mydriatic action. Mydriatics are those which produce mydriasis. Mydriasis, that is increase in the pupil size, is induced by atropinic drugs for examination of the eye. Usually when you go to a doctor, ophthalmologist, for your eye checkup, they will put some drops right into your eyes, and then what will happen, blurring of vision will take place. Usually what they do is they instill the mydriatics so that the pupil size is increased, so that the internal observations become easier. So what will happen is it will keep the pupils dilated for quite a long time, so you won't be able to move about on your own, because refraction will be affected to certain extent over here. Okay, so to counteract this action of mydriatics, once the ocular observation is over, to counteract the mydriatic action, it will reverse. When you give this pilocarpine, it will reverse the mydriatic action because it produces miosis. Okay, then another use is to prevent the adhesions in between iris and lens or iris and cornea, or to even break those adhesions which have already taken place. So here also they are used in alternatively with mydriatics. So for few days mydriatics are given, for few days miotics are given, and the adhesion can be prevented from being formed, or even if it is formed, it can be broken. Okay, for that purpose also pilocarpine is used. Then the next is muscarin. It is obtained from the poisonous mushrooms Amanita muscaria or inosite. It's actually only of the toxicological importance. Arecolin, it is obtained from the betel nut Areca catechu, and it also produces all the muscarinic as well as nicotinic effect. Okay, so this also has prominent CNS effects, because of which it is tried in the treatment of dementia, wherein the person has the problem with memorizing or remembering things. So to enhance the cognitive functions, it can be could be used. Okay, in the olden days it was tried, but then it was found that it is not quite very much effective. Other drugs of course have been found for this particular purpose, okay, as cognition enhancers. So we'll stop here. Thank you.